Okay, welcome back. Hope you guys enjoyed the vendors. I hope you got all the signatures. I do hear that Mark Drugs was not out there, so we'll forgive you for that. Somebody will still, win the $200 gift certificate. All right, let's jump into our next presentation. One other thing that I was told to remind you guys is that don't forget to complete evaluations. They will be online on the website. They will be the evaluations will be posted for tomorrow. Tomorrow will be when you can go on and do your evaluations, and then you will be emailed the response. Once you get that you'll be emailed the certificate. Yeah. Okay. All right. So let's jump to our next presenter. Our next presentation brings a little basketball flair to a very common urologic challenge. It is my pleasure to introduce Jeremy Lai, MD. Dr. Lai is a urologist specializing in the evaluation and management of kidney stone disease and other urologic conditions. His clinical interests include advanced endourologic techniques, minimally invasive stone surgery, and improving patient outcomes through evidence-based care and modern surgical approaches. Kidney stones remain one of the most frequent conditions encountered in urologic practice, affecting millions of patients each year and often requiring a combination of prevention strategies, medical management, and surgical intervention. Staying current with the latest techniques and treatment strategies is essential for improving patient outcomes and reducing recurrence. In today's session titled Crushing It, Slam Dunk Strategies for Managing Kidney Stones, Dr. Lai will review practical strategies for diagnosing, treating, and preventing kidney stones while highlighting advances in stone management that can help clinicians deliver more effective and efficient care. I was a little worried. I was a little worried that Dr. Lai, he is on call. So as long as we don't have a torsion in the next 45 minutes, we should be okay. So please join me in welcoming Dr. Jeremy Lai.
Wow, thanks for having me. That was a very nice intro. All right, so yeah, you guys know kidney stones are very common. So we get into this right away. So why does this matter to you, right? And so obviously, I think nurses come first in a lot of our patient care, right? I think it's kind of an obvious statement, but you guys are first contact for our patients and their symptoms. You're often our first contact for setting expectations with what it looks like when it comes to stones. You're often the first contact for post-procedural questions, right? You guys have all gotten questions about stents and such. And so our goals today are help us understand stones, help patients and help us counsel patients understand their symptoms, what their goals are for the treatment, and how to prevent stones. And so kind of a quick outline, we'll go over kind of epidemiology, why do stones matter, how do we find stones, kind of the management options, what that looks like medically, surgically, and again, really focusing on patient expectations, how we counsel and educate them. And then every patient's going to ask, how do I prevent future episodes? How do I prevent these from happening again? Okay, so kind of definitions, stones can form anywhere in the urinary tract. There are many kinds of stones. And today we're focusing specifically on kidney stones, kind of the most common. There are some other rare cases of like people with weird anatomy or prostate stones or bladder stones for other reasons. But today we're focusing on specifically kidney stones. So this is why we will continue to be busy, as Lori kind of hinted at. Kidney stones are happening more and more to more patients. 11% of Americans will have a stone, and there's been a big increase in stone prevalence from the early 1990s to now. Risk factors include age, 10 older patients. Again, just as you think about over time, more likely to form a stone, have a stone hang around, get bigger. Male sex, metabolic syndrome, as we all kind of know, this is has been increasing over the past few decades, and things that kind of lead to immobility. So if patients have a fall or have some neurologic condition where they're kind of bedbound or not moving around, that can lead to more stones. Kind of the peak incidence when they kind of show up to our clinic tends to be working age. And then traditionally, we were taught that men have more stones than women, but that gap is starting to shrink. And the latest data suggests that women might be a slight majority from kind of young adult age to 44. So, and then kind of a point again, addressing metabolic syndrome, every 5-point increase in BMI increases your stone risk by 21%. And then maybe for those of us who see kids, we also see more stones in the pediatric population as well. And so in the last 30 years, the incidence in kids has doubled to now about 1 in 1,000. And so again, that kind of is linked to some of the other things, especially with the metabolic syndrome stuff, as you see more kids being kind of having more central adiposity and weight. And so stones love to come back, right? So this is a big key point. Once you have stones, you're kind of always at risk for making more stones. And so we tend to follow these patients for a long period of time. The data is pretty mixed, but it suggests like up to a 40% symptomatic episode recurrence in 5 years from your first episode. So that's pretty high. And then if you look at kind of patients who get imaging for other reasons, they get CT scans, they're so common now, up to an 80% recurrence if you do nothing within 3 years, which again is quite significant. And if you look at these charts on the right here, show kind of how the costs of treating stones have decreased per episode across all different things, procedures, non-surgery management, stuff like that. But our overall costs are increasing because prevalence is increasing. And so if we can do the best job we can in prevention and lowering patients coming back, we can save a lot of costs for patients and for the whole system as a whole. And if you look here, like overall costs may exceed $5 billion a year just in the US alone. And that direct costs are things that we do directly, right? Patients come seeing us, procedures we do, medications, but there's also a lot of indirect costs, right? As we said earlier, a lot of these patients show up when they're working age, and you can imagine the time off needed to deal with their pain, their procedure, so on and so forth has a pretty significant indirect cost on our population, our system. So most patients, as you know, come with pain. And the key point is here, pain comes from obstruction of the urinary tract. Some patients can have stones, small stones that hang out in the kidney, and they kind of just hang out there and don't cause any problems. But as you can see here, when the stone kind of falls into the ureter and causes backflow of urine, the urine can't drain, the kidney capsule gets stretched, and that's what kind of leads to the pain. So some patients can actually pass stones that have no pain, right? The stones kind of fall down the ureter, they pee it out, they may not feel it. And what kind of pain is that? It's usually very severe, spasming pain, can lead to nausea and vomiting. Position and activity generally do not matter, right? Because usually if the stone is stuck in the ureter, if you're laying down or sitting up or standing, it doesn't really matter, right? The stone is stuck. So, and the mimics should be ruled out, right? So you want to make sure that, if it does seem to come about only with certain movements, maybe it's more musculoskeletal. Maybe it's a spine issue or back muscle issue. If associated with food, maybe it's more gastrointestinal than kidney stone. It could be gynecological as well. Right. I think everyone has heard that, this is the worst pain of my life. Right. And I think they've done some interesting studies. You ask women who've had childbirth, they say kidney stones are worse than childbirth. Now, obviously, a little bit of caveat, right? After childbirth, you have a baby, and after kidney stones, you have a stone. And so there's a little bit of a little confounder there, right? So, but generally, the point is that it's very bad pain. Okay. So. And so some patients will find their stones incidentally, right? They notice something they passed. But generally speaking, right, imaging is kind of the cornerstone for how we find stones. The other things we kind of talk about, like CV tenderness, right? Pain in the flank when you tap on their back, location of the kidney stones, that is generally present. And that again comes from the stretching the kidney capsule. So when you tap on their back, the kidney capsule will stretch, they're going to feel that. They're going to jump. Some people like to look at UA, the crystals, not super definitive, but they can be helpful. Hematuria is not always present, so you may not always see blood in the urine. Sometimes you can. Other tests are kind of more adjunctive. So you want a urine culture, just test for infection, and in a basic metabolic panel, look at creatinine, or kidney function, and then serum calcium, which we'll talk later why that's important. So imaging is the cornerstone, right? So what does that look like? And so here, KUB is kind of the oldest, the quickest form. You can see here, kidney stones tend to be hard. They're usually made of calcium. And so you can see here, it basically is usually the same color as bone. Okay, so here you see a little hitting. You also see here, like outline the kidney. That's not always present depending on the X-ray in the patient, but you can see here the kidney here, and this calcification is likely a stone. Some other little ones, so this is hard to see on this here, but there's a tiny stone here, and here you see a much bigger kind of white calcification here. This basically fills a whole system of the kidney. The kidney around here as well. But so you can see it can vary quite a great deal in size. But generally speaking, if it looks similar to what the bone looks like, then it might be a stone if it's in the area of the kidney. So KUB is best when stones are radio opaque, meaning they show up, they reflect to the X-rays. They're convenient, right? It's pretty easy to schedule a KUB. They're pretty cheap, or cheaper at least. But you can miss smaller stones, and then soft stones, like uric acid stone, are very likely to be missed. Because again, remember, it has to be as hard as bone to show up. Ultrasound, another kind of cheap way to look at kidney stones. You can see here, the stones will bounce the sound waves back, so they're bright. And so that's a pretty easy way to look at stones with ultrasound. And then behind the stone, you'll see this kind of shadowing. It's like a cone. And that's because, again, when the sound waves come down from the transducer, they bounce back. The stuff behind won't reflect anything back, so it's darker. And so you can kind of see these are two ways. Because there are some other things that can cause some brightness on ultrasound. So to know if it's a stone or not, you should see some shadowing behind. Now, in general, ultrasound tends to overestimate size a little bit, on average by 2 millimeters. Okay, so just a little tip for ultrasound. And again, it's nice because no radiation. It's pretty easily scheduled. It's cheaper, but ultrasound is very, very operator dependent. So and then it's hard for us to know who's doing it that day. Are they good at this or not, right? But it's just something to keep in mind. And again, small stones are easily missed, and then ureteral stones are very easily missed because most operators do not check the whole ureter, and it can be hard to. So CT is the gold standard. And again, we think about bright like bone. CTs are better at looking at size. As we discussed, ultrasound overestimates size. It's good at looking at the hardness, or what we call the Hounsfield units, the measure of brightness. This is important for letting us know what kind of stone it is, which can kind of help us think about what treatments are appropriate for this patient. It looks at the anatomy, right? So some patients have kind of odd anatomy, like a double ureter, duplicated system. They have a kind of a weird position in their kidney. These can also matter for treatments. And then I know people talk about CT as radiation, right? CT is basically a whole bunch of stacked X-rays. So a lot of X-rays. But we do have some lower radiation dose stone protocol CTs now. And if we look at this chart of radiation exposure, so you take these numbers, the millisieverts, think about first, just us walking around, we'll probably average 2.5 millisieverts a year, just walking around. A flight across the country, it's going to be, 5 to 10 millisieverts as well. So these numbers, they may sound kind of scary, but just realize in daily life, we're actually exposed to quite a bit of background radiation. So in KUB, a single shot is about anywhere from 0.2 to 0.6 millisieverts, right? However, typically when you order a KUB and X-ray nowadays, they usually do a few shots. And so it's actually not closer to probably around 2 millisieverts. And then there's some suggestions that, 1 in 5 patients who get KUBs or abdominal X-rays actually get the same dose as a low-dose stone protocol CT. A typical low-dose CT will be less than 3 millisieverts. When you think about other abdominal CTs that we get for other reasons, in the ER, for example, with contrast, you might get up to 9 millisieverts. And then if you do the urogram that we do in urology for hematuria, blood and urine workup, that can be up to 14 millisieverts. Now, it really depends on how they dose the contrast and how many phases they take. Some of the newer protocols, they do like a split dose bolus. They try to do the contrast phase with the excretion phase, can lower this dose down to around 8 or 9 millisieverts for urograms. So that can give a general idea of what it looks like and how to counsel patients about, hey, I know you're getting a CT scan or getting this, but this is actually how much radiation you're getting. So say hey, a low-dose CT is about the same amount you get over a whole year, just living life here. So what about treatment, right? And so I think, pain management is obviously the key. Generally speaking, NSAIDs, so things like ibuprofen, Advil, Aleve, Motrin, Toradol are more effective than opiates, okay? These tend to be a little more direct acting on the basic think about selecting the kidney stretching more effectively than opiates. Opiates kind of block at the pain at the spinal cord and then the central nervous system. And so we usually tell patients, hey, if your stone is less than 5 millimeters, you're going to have a pretty good chance of passing the stone, about 80% chance or better. And so sometimes we use alpha blockers like tamsulosin or Flomax, although the evidence on this is quite mixed. There have been multiple kind of meta-analyses where they group a bunch of studies to see, do alpha blockers actually help? Generally speaking, again, it's mixed, but if you look at the subgroup analyses within these studies, there may be some benefit for stones that are bigger than 5 millimeters and that are distal. And so now in practice, we kind of just give this to everybody, right? Because again, the harm and the risk is pretty minimal. And so if the evidence is mixed and it can help in some groups, we kind of just give these to everybody. And we usually give patients, hey, we'll give you a week or 2, but if you're still having a lot of pain, you should just come back to the ER. Right. And so we've all seen patients, they come to the ER, get us with a small stone, they get sent home, but they call back a day later, my pain is still terrible, I'm still throwing up. they should probably go back to the ER and get this treated. And what does that look like, right? So there are kind of three kind of main ways to treat kidney stones surgically. And so the first one you may have heard about is shockwave, right? Lithotripsy. This involves a patient. It used to be you lay down in an actual bathtub, but now they have machines that just have like a water tube that goes to your back. And so they send shock waves and they're targeted using x-rays and fluoro. And the pros of this is non-invasive, right? There's no energy, there's less injury risk to the urinary tract in terms of the ureter and stuff like that. The cons are that it requires stone invisible on x-ray. So as we discussed, they need to be radiopaque or pretty hard stones. There's actually lower stone passage rates. I think some of the research from when ureteroscopy first came out, which is a different technique we'll talk about, showed that the stone rate passages were the same. But I think the issue is that the modern shockwave machines are actually probably not as good as the old ones with a full bathtub. So it's a little more convenient for patients. It's easier to kind of manage and stuff. But some of our stone experts, national stone experts, have looked at, hey, the machines these days are just not as good as the ones before. And another con is you don't get a stone for analysis, so patients may not know what kind of stone they have, which can be helpful for counseling for later on for prevention. I tell patients it's like getting slapped in the back 3,000 times. Okay, now you're usually under like MAC anesthesia or like IV sedation, so again, you're usually pretty comfortable, but you might wake up feeling pretty sore back there. But because it's like getting slapped 1,000 times, you cannot get this if you are pregnant. You cannot get this if you're on blood thinners. And the CT scan is important for this because if you're really, really obese, if your skin to stone distance as measured on CT scan is more than 10 centimeters, you can, but it's not likely to be effective. There's just too much tissue in the way. And so those are some reasons that you cannot get this. Uteroscopy is kind of what we do the most now. The pros of this, because it's not that invasive. We pass a very small camera through the bladder, out the urethra, out the ureter, find the stone, and use a laser to break it up. Very good success rate because we are visually confirming. We're literally watching, and so we are there to remove all the fragments. And then, or we can turn off the dust, and the patients will pee out the fine dust or sand after the procedure. The cons are, the lasers these days are very, very advanced, and the energy doesn't go very far from the tip of the laser, but there's still energy being delivered. And so you can imagine there's a risk of thermal injury to the ureter or the kidney. To see, there is water or saline that goes through the ureteroscope to kind of open things up so we can see. But that puts pressure on the kidney and on the system, and that pressure can cause damage or even risk of infection to the system. You can imagine, right, if you have a camera in here, and let's say the camera's up in the kidney, and you have a lot of flow of saline, basically giving the patient hydronephrosis or obstruction. It's kind of like a pseudo obstruction. You can cause backflow of fluid from the system into the bloodstream. Right? Remember, each kidney gets about 10% of the body's blood supply at any given time. There's a lot of blood flow, right? So sometimes stones can harbor bacteria, right? So if you have even if negative urine culture, if you're blasting a stone and there's a lot of pressure in the system, there's a chance of blowing bacteria into the bloodstream. And so we'll talk about later about things to watch out for. But that's why, like, even nationwide, there's like a 15-20% chance of UTI after a procedure like this, even with a negative culture, for the pressure reason. And then, of course, there's always the possibility of placing a ureteral stent after the procedure. So by our guidelines, you don't need to place a stent if it's just a one-sided procedure, uteroscopy. But in practicality, we tend to leave one because we always have stories of where you don't leave one, patient comes back, they're in terrible pain, they're throwing up, and you just don't want to put patients in that situation. Finally, there's PCNL, which is where we go through the back. A little more invasive, but it's really good for really, really big stones. Things that you may have heard like staghorn stones, where there's stones in every part of the kidney collecting system, right? Uroscopy, you can do it, but it would take much, much longer. The cons are obviously more invasive. There's a much higher risk of bleeding, much higher risk of infection. Now, the cool thing about more recently is we have some pretty cool new ureteroscopes and like different ways to kind of get the camera up the ureter with different sheaths, with different technologies. We can measure pressure with some scopes now, that even some of these stones that used to be PCNL worthy can actually be done ureteroscopically. So for example, using a couple of new techniques and equipment that we had just this past week, we did 3 centimeters worth of stone via uteroscopy. We did that in like about an hour and 10 minutes, which is pretty good, right? 3 centimeters of stone, even just 5 years ago would have been straight to a PCNO. And so this is changing a little bit, but you should know, tell patients, hey, if you have a really big stone burden, why don't you put a tube in your back? Now, expectations, right? The dreaded ureteral stent, right? So typically we leave this so that the ureter, I tell patients, it heals in a normal tube shape, right? We don't want there to be swelling, scarring afterwards that kind of causes obstruction, and then you're back here with terrible pain and nausea and stuff like that. And so we usually leave it in there to kind of, again, help the ureter heal in a normal manner. Most patients will tolerate the stent just fine. Okay. There's no data behind this, but anecdotally, younger patients tend to feel it more, and younger men tend to feel it the most. Okay. But that's totally anecdotal. So, but adult patients who are younger, yeah, you might notice this more. Particularly, I tell patients they may feel like a UTI. The stent is a foreign object, right? There's a curl in the bladder, a curl in the kidney. The bladder is, somewhat sensitive, so it senses this thing, says, like, why is this here? And it's going to squeeze and try to push it out or spasm, right? And that feels like urgency and frequency, because you feel like you have to go to the bathroom more often. The stent may rub around on the inside of the bladder, cause a little bit of bleeding. It's expected. May cause dysuria or burning, and that's from the stent rubbing around the floor of the bladder. That can lead to this kind of sensation of always having pain when you pee. And then sometimes the stent, by definition, keeps things open, right? And so you can imagine sometimes when the bladder squeezes, when you are voiding, the urine can go backwards up the stent and cause some pain in your back when you pee. So that can be expected. And then sometimes, again, it's a foreign object. Some patients who are sensitive can just feel the stent all the time, and it's super bothersome. So things that you can do to help with this, again, NSAIDs are helpful if their kidney function can tolerate. Always tell patients to take NSAIDs like Advil, Aleve with lots of water and with food, ideally, to prevent GI complications. Flomax, again, the theory is that it can help the ureter relax a little bit and maybe decrease sensitivity. That's not proven, but we do it because it's safe and again, upside and minimal downside. Pyridium helps with dysuria, right? Tell patients to make sure urine orange. So not be surprised at that. Muscle relaxants. This is also a little controversial. You kind of want to avoid in older patients, but things like Flexeril, methocarbamol can be helpful. Sometimes I think it just helps because it makes them just relax in general, but yeah, if it helps them, it helps them. Stent removal. So sometimes we leave it on a string, kind of like a tampon, and tell patients, go in the tub or go in a hot shower, take an Advil before, try to relax, and then pull it out in one smooth motion. It's weird for most of our patients, but especially our men, but it's usually quite tolerated. We also tell patients, hey, if you're really freaked out by the string, come to our clinic, we'll pull it out for you. And then sometimes you want to leave the send in for longer, for like a week or more. Then we have them come back to our office, and we'll do an office cystoscopy, pull out in the clinic then. So, and there are also some newer technologies too, with some more modern stents are theoretically softer and have less discomfort. We did an interesting study over at Kishwaukee where they replaced all their old stents with what they call the Tria soft stents. And anecdotally, they had less stent complaints. So I think CH, we're going to start doing that as well over here in the West Burbs with Northwestern. But so yeah, I think these are always trying to make things better and advance things for patients. So what are the red flags for triage, right? So if a patient comes to us and tells you, hey, I'm having terrible pain, it sounds like kidney stone, probably serious stones. If they also have signs of infection, that's an emergency, right? You can imagine, like we talked about before, when you have pain, that means urine is blocked, right? Urine is stuck. And if urine is stuck and it's infected, and each kidney gets 10% of your body's blood flow at any time, that bacteria can make you very sick very fast, right? And so if they have fevers and chills, they're lightheaded or dizzy, even they're orthostatic, they have new burning with urination, you should tell them, hey, maybe you got to go to the ER so we can make sure that you don't have a UTI and a stone. If they have intractable vomiting, can't get anything down, they can't eat or drink anything, they should also go to the ER because, you can't live life without being able to eat and drink things for a certain period of time. If they have terrible pain, uncontrolled pain, and multiple ER visits, also should proceed to the hospital for treatment. But it's really specifically, again, emphasizing a stone and infection is an emergency. This requires a stent placement to drain and relieve the obstruction. Again, mortality from an obstructed infected urine tract can approach 20%. Even after a stent placement, some data suggests mortality is still 9%. So it's still pretty high because, again, the kidneys receive so much blood flow. When there's an infection there, that can make you very sick very fast. Sometimes you cannot place a stent, from below. That can be because a man's prostate is too large, weird anatomy, or the stone itself is so stuck in the ureter, you cannot get a stent past it. If that's the case, then you got to place a nephrostomy tube in the patient's back. We'll call our interventional radiology friends to help us out. But the goal, if there's an obstructing stone and infection, is to relieve the obstruction. You cannot treat a kidney stone with an active infection. The reason for that is, again, like we talked about before, you put a lot of pressure in the system when you're treating a stone. You would make the obstruction worse, and you would blow more bacteria into the kidneys, into the bloodstream. Bacteremia and sepsis is very possible. Like I talked about before, even if you have a negative urine culture and a patient had documented UTIs, even a negative culture at the time of surgery, you can put someone in the ICU by treating the stone. Not common, but it's possible. Again, emphasizing the importance of how dangerous obstruction can be for patients. So consider similar warning signs post-intervention. Okay. So again, we talked about UTI, 9 to 14% after SUNA intervention. It's not always sepsis, right? So I tell patients, if you have a low-grade fever, it may just be post-procedural inflammatory response. Getting anesthesia, getting surgery is stressful on the body, right? Regardless of whatever surgery you got, your body's going to be in a bit of a sympathetic response, fight or fight, nervous system response. And so you can have tachycardia, low-grade fevers after any surgery, right? And so you want to think about what are the real alarm signs, right? If they're hypotensive, they're dizzy, they're lightheaded, they have rigors or shaking, they have persistent fevers, right? You might have 100.5, let's say like the same day, same night of surgery. That's okay. But if the next day you're still 100.5, 101, then you got to say, hey, come back, give a urine sample, or go to the ER to check for postoperative complications. Some studies also looked at, hey, what if we give antibiotics to everybody around after procedure? Doesn't seem to make a difference. Again, illustrating that, hey, even if you give antibiotics, because most patients get antibiotics around surgery, right? Just the fact that if you have a lot of pressure in the urinary system, again, that backflow of urine, bacteria into the blood, it doesn't matter sometimes how much antibiotics you give. All right, what happens afterwards, right? Again, like I talked about, stones love to come back. So some patients may ask you over the phone, hey, what can I do to lower the chances of happening again, right? And so general tips. Dietary is a big one. Increase fluids. We'll talk about how much exactly later. But tell people, hey, drink more water, lower the salt in your diet. A lot of patients have calcium, so they're like, should I take less calcium? Should I avoid calcium? You do not want to avoid calcium. You can paradoxically increase your stone risk by cutting out calcium in your diet. So tell patients to continue eating calcium. You guys may have heard high protein is all the rage now. Lower animal protein if you want to lower your stone risk. Okay. And then work on medical comorbidities, right? Metabolic syndrome is huge, huge, huge. And then just think about, actually kind of interesting, the latest data suggests that with GLP-1s, obesity rate has actually plateaued, which is kind of good in the last couple of years. But plateaued still means, a lot of metabolic syndrome still in our country. So things to kind of consider and think about. Hyperparathyroidism, that's when your parathyroid glands make too much hormone and make your body have too much calcium. And so this is what a BMP or basic metabolic panel can look for. If you have a high serum calcium, they should be worked up for hyperparathyroidism. GI conditions, if you have things like Crohn's, chronic diarrhea, and you have kind of impaired calcium and oxalate reabsorption to the body, these can lead to calcium stones as well. So if they have a lot of GI conditions, just have a little bit of a heads up on those. Osteoporosis, right? As we get older, this is more common. Osteoporosis is the resorption of bone, and bone is made out of calcium. So if you're taking away bone, that means calcium is going into your bloodstream, which is coming out of your kidneys, can lead to stones. So things to kind of think about. So these are kind of general tips that you can talk to patients about. How we, and you guys may have obviously have done this, 24-hour urine collections. This is kind of a little better way to kind of look at what are patient-specific risk factors. Because again, calcium stones are the most common stones, but again, 10 patients can form calcium stone for 10 different reasons. And so doing these collections can help us understand what is a patient's specific risk factors. And so the instructions I tell patients, this can obviously vary a little bit lab by lab. It's time sensitive. You want to return the container in a timely fashion, start and stop the collection in a timely fashion. You want to add the preservative first. I think the old ones had to be refrigerated. The new ones these days do not, which is kind of nice. But then they got to tell them don't put it in the fridge. Don't take vitamin C because that can alter the test. That's just the most common supplement that can alter the test. Considerations: people's diets do change, right? Weekday versus weekend. So ideally, you get a weekday, weekend. Ideally, you repeat it in some interval afterwards. Practically, do we do this? Probably not as much as we should because it's cumbersome, right? You got patients to come to the lab, pick up this jug, take it home, time a collection, bring it back in timely fashion, and that can be hard for patients in their busy schedules. So this may not always happen. But what do we look for, right? So things we look at: urine production, how much urine you make; urinary citrate, this is probably the most important stone inhibitor; urinary calcium, urinary pH, or the acidity level; oxalate, sodium, and uric acid. So for each of these things, what are we going to tell our patients? For urine production, the goal is to make 2 liters of urine a day. That is actually really hard. Because to get 2 liters of urine a day, you got to drink more than 2 liters a day, right? Because you lose some in your activity, in your sweat, your breath, in your bowel movements. So you got to drink quite a bit to make 2 liters a day, right? For citrate, we have medications we can give: potassium citrate, 20 milliequivalents BID, or if some patients, the citrate is kind of big pills. They're kind of hard to swallow for some patients. So 2 to 3 ounces of lemon juice twice a day can add some citrate to a patient's diet. For calcium, like I talked about, you don't want to limit calcium. You want to maintain a good calcium intake, 1,000 to 1,200 milligrams a day. The reason for this is that calcium in the gut will bind oxalate and keep it from getting absorbed. And so even just getting up to 1,200 milligrams a day of calcium can drop your oxalate absorption by like 2/3. So this one thing, if patients are avoiding calcium, can really drop their recurrence rate quite a lot. For pH, usually, not all, there are some exceptions, but generally speaking, acidic urine or low pH promotes stones. Okay, so generally speaking, one of our first treatments then is potassium citrate again, because it addresses the pH and the citrate. But some patients who can't get potassium citrate for whatever reason, you can also do a quarter teaspoon of baking soda twice a day. Very cheap, right? Baking soda is pretty cheap and it's pretty easy. You can't really do that in patients who have uncontrolled high blood pressure, though. So just be careful with that. But again, it's a good alternative. For oxalate, I actually really don't tell patients to limit oxalate-rich foods because these tend to be healthy foods. Dark green vegetables, nuts. And so I usually say, hey, it's better to increase calcium intake to prevent absorption of oxalate from the gut than it is to limit these healthy foods. So, but that is a tool in your back pocket if they've done everything else on this list and you're kind of running low on options on next steps. But generally speaking, yeah, I don't tell them to limit these foods. This is a big one, limiting sodium. The American diet is very, very high sodium, and sodium, when it's excreted in the urine, tends to take calcium with it. So that's why limiting sodium, you have less sodium being excreted into the urine, being put in the urine. It also means less calcium being put in the urine, which means lower stone risk. This is admittedly very hard for many of our patients, but something to keep in mind. And then, like we said earlier, lower animal protein, right? So keto diet, carnivore diet, high animal protein diet, these are generally not good for stone formation. So like you kind of tell from all of this is the typical things, just eat healthy, right? So like these are things most patients already kind of know, but having a stone, wanting to prevent stones may be the good final push for our patients to kind of actually make changes, right? Other things, we do have medications. Our thiazide diuretics reduce calcium in the urine directly, right? Chlorthalidone is generally our first line, but our second line can be indapamide. Hydrochlorothiazide used to be kind of the first line, but that's kind of less preferred because it's not quite as good at actually getting the calcium out. When you're on these medications, you got to check labs. And so with some of these medications, you may need potassium supplementation, which you think about, right? Potassium citrate works well, right? Because it also works to address your pH, acidity, there's a citrate, and can also help with if they're on a thiazide already to kind of replace some potassium. Potassium citrate is a big pill, so it kind of can give some patients GI upset. And you have to be careful if they have bad renal function, they might not be able to get potassium citrate. Supplements. Some patients will come and ask, oh, I found this on Amazon. Can I take this, right? Litholite and moonstone are actually pretty good. They tend to have a lot of citrate, a lot of magnesium, which we can talk about magnesium. It can also be a stone inhibitor. They tend to be pretty safe. They don't really have a lot of side effects. And so they can take these things. Crystal light is another kind of drink additive, has a lot of citrate, can be helpful. And then lemon juice, like we talked about before, you take a fresh lemon or like one of those lemon juice concentrate things twice a day to your water. And you can also use these as ways to have them increase their fluid intake. You know, give them one of those big Stanleys or Owalas or whatever, right? And say, hey, drink 2 of these or drink 1 of these in the morning, 1 at night with lemon juice and Crystal Light. And that can usually get them pretty close, or at least get them much closer to their urinary goals. Things to avoid. So again, keto, carnivore diets. People take too much Tums. That gives you too much vitamin D, too much calcium. That can kind of, so there is a limit on how much calcium you do want to take. You don't want to take too much either, because that can also increase stone risk. Vitamin C makes you prone to oxalate stones. Topiramate, some patients who are on this for anti-seizures or other reasons, that can lead to calcium stones as well. And then patients who are HIV meds or antiretrovirals, that can also lead to stones. Usually, if you're on this for a little bit of time, it's not a big deal. But if you're on it for a long time, like decades, that can lead to stones. What is weird about these stones are very not radio opaque. Like, this is the only stone that CT scans won't catch. It's a very rare thing. But if you have a patient who seems to have terrible pain, looks like a kidney stone, smells like a kidney stone, but you don't see anything on a CT scan, but they have like obstruction, hydronephrosis, and they're on HIV meds, you can consider, hey, maybe we still go to the OR, take a look, because these stones do not show up on CT scan. It's a really, really weird and rare exception. So some takeaways, right? So stone management is a team sport for all of us, right? We will encounter more and more stones. The big thing is know when stones need something emergent. So again, obstruction and infection is really, really bad. There are lots of treatment options, 3 main ways, but most of the time we just use ureteroscopy now. But set the appropriate expectations, especially with stents, and what to think about before, during, and after procedures. And then long-term follow-up is needed, right? Once you're a stone former, you're always a stone former. And so these patients should be followed up. There are general tips about fluid intake, how much pee you want them to make. 24-hour urine collection can be helpful, and there are different meds, supplements like that we can do, and things to alter and change. We can really drop recurrence rates. Let's say, for example, some data suggests 50% recurrence rate in 10 years. With appropriate metabolic eval and counseling, you can drop that to 20%. Not great, but 20% is still better than 50%, right? So, and if you need references, these are the references in this presentation. So, any questions? Yeah.
For a patient who has a first stage, or you get it out right away versus a stent needing a second stage.
Yeah.
Are there post-operative concerns that are different, one versus?
No, not really. It's the same things. You're looking for post-operative UTI, post-operative obstruction, the same thing. Yeah. Yeah. Yeah, it's a great question. Great question. So the data suggests that if you have small stones, usually defined as less than 4 millimeters or so, they're hanging on the kidney. They're not causing any problems. They're not blocking anything. No symptoms. There's about a 5 to 7% chance every year that they will cause a problem. So it's not very high, right? 5 to 7%. Are you going to operate on someone for 5 to 7% chance of there being an episode in a year? Hard to say, right? Very patient dependent. Now, that being said, there's also some debate. Can you do a urine collection with someone with current stones? Right? I tell patients, it's a little bit like trying to measure the saltiness of a glass of water. There's a salt tap at the bottom. Kind of messes up the test a little bit. But some doctors say, hey, let's just do it anyway, because it can still be helpful to a degree, especially with urine production, right? That's not going to change if there's a stone there or not, how much urine you're making. And sometimes showing a patient, hey, you only made 600 cc's of urine today. You really got to jack that up, work that up, right? And so that can be helpful, even if they have a stone sitting up there. But you're right, the small stones sitting in the kidney, that is a very personal decision for a patient whether or not they want to go after them or not. Now, if they have recurrent urinary tract infections, that may be a reason to go chase after those, because stones can harbor bacteria. The reason why you can have a negative urine culture but still have a UTI after stone treatment is that bacteria can live within the stone itself. The stones are not solid. They're basically these matrix-like interlocking crystals. So bacteria can live within the stone. And that's why you may treat them for UTI, and then afterwards the bacteria comes back because they reemerge from inside that stone. So for those patients with recurrent UTIs and known stones, if they're not obstructing, treatment should be considered. But if they have no UTIs, they're just hanging out there, you also could choose to leave them alone. Yep. Oh, CVACing? So actually, we tried CVAC. So CVAC, if you guys don't know, is a technology that is a scope that can actively suck out stone dust and fragments at the same time while you're up there. So a bit of a bigger scope. It actually has a black box warning because they're having issues where the suction channel in the scope gets blocked with the stone dust and fragments, and then the pressure in the kidney shoots up, and people have died because of that. And so for that reason, at Northwestern, we have decided to not use this equipment anymore. The reps are still after us though. So yeah. But yeah. There are some other cool kind of technologies where we have the axis sheath that does the suction itself. So the scope does not have the suction, but the scope puts a fluid and then the sheath around it can suck that fluid out and any dust or blood or anything out pretty simultaneously. And that tends to be, at least so far, it seems much safer. No one has had issues with this, and it does. And this is one of the main reasons why we can do multi-centimeters of stone with just a ureteroscope. So, you had a question?
For women with, or anybody that has osteoporosis,
Yeah.
Replacement, like how do you like take care of that?
Yeah.
Constantly creating stones.
Yeah, that's a good question. So I obviously don't manage osteoporosis myself. So I tell them, hey, you should talk to your primary doctor or talk to someone who's an expert in that field, but to get it addressed. Yeah. And again, for a lot of people, especially for maybe women who are, I see younger, like the best way to prevent osteoporosis is just like kind of be proactive about it, preventative stuff. So, yep.
Someone with a history of Staghorn stone, what would be their likelihood of number one happening?
Yeah, so people with Staghorn stones are people who tend to have other medical conditions that lead to the Staghorns, right? So, for example, people who are paraplegic. So, when I was downtown, I saw patients who had gunshot wounds to the spine, and they're paralyzed, they can't move, they're catheter dependent. They tend to form Staghorn stones because they're immobile, right? And so those patients are always at risk for more stones. And so those patients you might consider a more updated surveillance or screening. Maybe we can try to do low dose CT scan, maybe every even 6 months or a year to try to catch them before they become full Staghorns. Other patients who have genetic conditions like cystine stones, these tend to be young patients who form Staghorns very quickly because of a defect in their metabolism. Those patients also require more frequent updated surveillance. And I've had patients who had multiple PCNLs, like once, twice a year PCNL, because their stones are so fast and they're not compliant with their medications. So patients with Staghorn stones tend to form more Staghorns because of their other medical problems. Yeah, so they may need closer follow-up. And for them, the 24-hour urine collection may be less, actually not really needed because you already know why they form those stones so frequently.
How long can a ureteral stent stay in place before it becomes encrusted?
Yeah, that's a good question. So the older stents that we used to say no more than 3 months. And in some patients might be sooner than that. If, let's say you put a stent up because they have a obstructed infected stone, so there's stones with the stent, more likely to encrust. If you clear out the system, put a stent in, less likely to encrust, assuming they made dietary changes and such, and drinking lots of water. The newer stents, like for example, the Tria or the Bard Optima, these stents, the manufacturer says up to a year. So what we usually do is start at 6 months if patients who need stents for other reasons. Stent for 6 months, we come in and look. If it's super clean, then we extend the duration. Maybe we do 9 months, and then we do 12 months. The longest I've seen is 18 months with one of the Tria stents. But again, those people tend to have the stents for a long time, not for stone reasons, for other reasons, right? So typically in our stone patients, the stents are not in long enough to really cause a problem. That being said, you always have patients who get lost to follow-up, come back, years later, and they have a super encrusted stent, and that requires many procedures, and it can be quite an ordeal for everybody involved. So it is important for us to make sure we kind of keep track of those with stents and really kind of make sure they follow up appropriately.
We had a trauma patient.
Oh.
Our stent who didn't really realize
Yeah.
what he was doing with it, and we came in a Staghorn.
Yeah. So those are very, very challenging. Yep.
Patients that we're telling them to increase their fluid intake, take bladder irritants, and then they're complaining about urinary frequency.
Yeah. It's definitely a trade-off. You drink more water, you're gonna pee more, right? That's just and then also you can. Yeah, there's obviously the treatment for like overactive bladder frequency is a whole other discussion and whole set of meds and risks and benefits. But you can, right? If patients like they're drinking 2 cups of coffee a day and trying to get 2 liters of urine a day, yeah, they're gonna be going a lot. Right. And so it's always a balance and trade-off of look, you want to reduce your stone risk. You're okay with peeing a lot. Does your job allow you to pee a lot? Right. Some of our patients who are teachers or drivers, they can't go to the bathroom a lot, or even us, us in healthcare. I probably don't pee enough. Right. And so, like, what does that look like if we're trying to pee 2 liters a day? That's hard. And so it is a very nuanced discussion for a lot of our patients. Yeah.
I'm not so sure you mentioned soft drinks or artificial sweeteners.
Yeah. So typically, there's no good data on like sweeteners and kidney stones. Soda probably promotes kidney stones a little bit via the acid load. And then there's some data too that like, yeah, if you drink a lot of soda, like the phosphoric acid can be harmful for your bones and kind of leach calcium off your bones. So yeah, definitely avoid soft drinks. That's again, the patients when they hear these things, they're like, oh yeah, I know. Because again, all patients know what healthy living, healthy diet should be like. Everybody knows, right? There's not some secret sauce to it. It was just like actually doing it is hard, right? And that's the problem. All righty. Well, Lori has my contact information if you want to reach out with questions. Always happy to help. Okay. Yep.
So here's to the mornings, the coffee, the monitor glow, to the wisdom he shares and the folks that he knows. Saturday is special when Vic's on the stream with 40 years of knowledge and a head full of dreams.